Dear brothers, today, as discussed, we are going to talk about one of the common medical problems, which is diagnosis and management of arrhythmias. Now, as we all know, arrhythmia is in fact a misnomer. By A we mean absence and rhythmia is rhythm. So when we talk of arrhythmia, it literally means absence of rhythm. It should ideally be called dysrhythmia because what we see in our day-to-day clinical practice, it is in fact disturbance of cardiac rhythm. Now, disturbance of cardiac rhythm is a common problem which we see in our day-to-day clinical practice. And I'll keep it very brief, and at the same time I'll try to put across as to how do we diagnose cardiac dysrhythmias and how best we can manage them. The very first thing which we diagnose is by examining the pulse. Now, if you palpate the pulse, which is commonly the radial artery which we palpate, you find that normally the heart rate is between 60 to 90 beats per minute, and then it is fairly regular. In certain situations, we find that the heart rate increases, and when it increases beyond 90 or 100 beats per minute, it is called tachycardia, and that is a fast heart rate. And if the heart rate drops from less than 60, then it is called bradycardia. These are the two commonest disturbances of heart rate, that is tachycardia and bradycardia. Now, tachycardia, as you all know, can be physiological, that is, if a person gets excited for one reason or another, he can have a fast heart rate, or he exercises, he can have a fast heart rate. During most of the fevers or infections, a person can have fast heart rate. And the slow heart rate or bradycardia can be in people who are used to exercise, in athletes particularly. In patients, we've seen that people who exercise regularly or who are cycling regularly, they usually have a slower heart rate. One of the Olympic champions who won the gold medal had a heart rate of 40 beats per minute. So bradycardia without any symptoms can be a normal phenomenon. But bradycardia can be a symptom of disease also, or side effects of many other factors. For example, if a person is taking drugs, and in that if he's taking digoxin or beta blockers or calcium channel blockers, particularly verapamil, the heart rate decreases and may decrease tremendously, and that will cause bradycardia. Or if a person develops certain forms of fever, and relative bradycardia is seen in typhoid fever, and it is also seen in viral infections. So bradycardia has a number of reasons, and in order to treat bradycardia, we have to get rid of the offending agents, stoppage of drugs, curing fevers. Time for tachycardia, we have to take care of anxiety, reduce your exercise, that will also take care of tachycardia. But certain pathological conditions can also cause tachycardia. For example, an overactive thyroid state, like thyrotoxicosis, can be a cause of tachycardia. And a rare disease, what we call as pheochromocytoma, can also cause tachycardia. It is important to differentiate between tachycardia, which is benign in origin, like after exercise or with anxiety, and tachycardia, which occurs because of a disease entity. It is a very simple test to differentiate between and physiological causes of tachycardia. Supposing a patient, an individual, a young lady comes with anxiety, she will have tachycardia of 120. Another patient with thyrotoxicosis can have tachycardia because of overactive thyroid. Now, in order to differentiate these two, the important thing is, besides checking the blood hormones, you just check the resting heart rate during sleep. If a person is asleep and the heart rate turns back to normal, then this is physiological. But if the heart rate remains high even during sleep, then it is because of thyrotoxicosis or pheochromocytoma, when it is in that stage where it causes tachycardia. So that is a simple test of diagnosing a patient with thyrotoxicosis and differentiating it from anxiety. So whenever you see patients who have either tachycardia or bradycardia, consider certain physiological factors and at the same time consider certain drugs which can cause either tachycardia or bradycardia, and you treat the offending agent, and rarely you can do certain tests in order to diagnose this. One of the other commonest dysrhythmia is what we call as the missing beats, the ventricular ectopics or ventricular premature contractions. Now, when you are checking the pulse of these individuals, you find that there is a break in the pulse, a break followed by a long pause. Now, that is the compensatory pause which you see in almost all cases of ventricular systolic ventricular ectopics or ventricular premature contractions. These are the commonest causes of, one of the commonest cause of dysrhythmia. You can also have atrial ectopics. They would also give you the same sort of radial pulse information. And one of the crude tests, which is not definitive, but a fairly crude test, is you exercise these individuals who you find have missing beats, and if the heart rate normalizes, that is, you find that there is no rhythm problem now, this is most likely benign ventricular ectopics or benign atrial ectopics. But if the ventricular ectopics are many, or if they are severe, then obviously you have to think of certain of ventricular premature contractions. I'll name some of the common dysrhythmias and then we'll discuss the management accordingly. So tachycardia, bradycardia, ventricular premature contraction, and then one of the commonest dysrhythmia is atrial fibrillation. Atrial fibrillation, when you check the pulse, you find that the pulse is irregularly irregular, and in large number of cases, the heart rate or the pulse rate is fairly high. So the pulse may be over 100 beats per minute. There's no regularity either of the heart rate or of the heart rhythm. Another condition which is less common is atrial flutter. It is usually regular, but there are missing beats in that, depending on the degree of block. We have supraventricular tachycardia, which in fact is a very fast heart rate. Suddenly, from a resting heart rate of about 80, it jumps up to about 160 beats per minute. So usually it jumps and becomes double, and it is usually very regular. There's then certain other dysrhythmias. One of them is nodal tachycardia, which is again a very fast heart rate, very difficult to diagnose just on clinical examination. There are certain ways to do that, but it's usually an ECG diagnosis. We have ventricular fibrillation, which is a very serious condition, and usually the patient collapses with cardiogenic. Also ECG examination or the heart rate or heart rhythm seen on the monitor. We have ventricular tachycardia, again, very fast associated with this. Then it is diagnosed by seeing a patient or on an ECG examination. Besides these common dysrhythmias, there are three other conditions under the title of heart blocks. You have the first degree heart block, which cannot be diagnosed by simple clinical examination. It is usually diagnosed on an ECG. Degree heart block, where you can have a heartbeat with drop beats. So when you check the pulse, you find 2 regular beats, followed by a drop beat, or 3 regular beats, followed by a drop beat. So this is either 2-to-1 block or 3-to-1 block. Or it could be a third degree heart block where there is a total dissociation between the atrial contraction and the ventricular contraction, and the heart rate or the pulse rate in these cases is fixed. In other words, it may range somewhere between 30 to 40 beats per minute. So if you find a fixed heart rate of between 30 to 40 and it is slow when you count it, in 9 out of 10 times you can diagnose as a patient with complete heart block, particularly if he is symptomatic. As I told earlier, a patient, an individual with who is an athlete can also have a very slow heart rate. So the differentiating point would be an ECG, which will determine either it is physiological or it is organic in the form of complete heart block. So those are some of the commonest types of dysrhythmias. We started with heart rate, tachycardia, bradycardia. Then we started with ectopic beats, which may be atrial ectopics or ventricular ectopics. Then we talked about supraventricular tachycardia. We talked about ventricular tachycardia, ventricular fibrillation, and the 3 forms of heart block. Now, for all these different forms of dysrhythmias, you have to look at the monitor or perform an ECG with a long lead 2. Long lead 2 is one of the best diagnostic ECG tests to diagnose various forms of dysrhythmias. We know tachycardia can be diagnosed with a heart rate which is more than 90 or 100 beats per minute, and we have discussed the causes. Bradycardia, as I mentioned, can also be diagnosed, and we have discussed the causes, and you have to remove the offending cause or do certain blood tests. We know in hypothyroidism you have a low heart rate, so if you check the thyroid functions, you can either diagnose thyrotoxicosis or you can also diagnose hypothyroidism. Coming to ventricular premature contractions, as I mentioned, this is a benign condition in a large majority of cases. You exercise these individuals, you find that these benign contractions disappear. If they do not, or if they persist, then you have to carry out other tests like an ECG for evidence of ischemia, do certain blood tests if the patient has had first time dysrhythmias, and then you can diagnose that on an ECG or blood enzymes for cardiac biomarkers. Supraventricular tachycardia again is an ECG diagnosis where the heart rate is usually 160, 180, or maybe 200. And most of these patients give a feeling as though there is a fluttering sensation within the chest, and they get a feeling of impending death. Although this is usually not a very serious condition. So what you do is ask the patient to lie down. You do a carotid massage. By carotid massage, what you do is you put your thumb on the just below the mandible at the level of the connection between the sternocleidomastoid insertion, where you can feel the carotid artery, and you start massaging it. So you massage it not from side to side, from above downwards. So when you massage an individual from above downwards, you are stimulating the carotid body. And we know that carotid body has parasympathetic system in it, and in that you can stimulate the parasympathetic system, and you can reduce or suddenly abort the attack of supraventricular tachycardia. Be extremely careful to ask the patient to lie down flat, because while massaging the carotids, a person can have a severe drop in blood pressure and can faint. Never ever do a carotid massage simultaneously on the two sides, right and left together. Always do it one at a time. And again, in large number of cases, you achieve success and the heart rate returns to sinus rhythm. And you can see it on the monitor, or you can check it while auscultating the heart rate if you do not have a monitor in your clinic. The other method of treating supraventricular tachycardia is asking the patient to take very cold water so he can drink that, which is usually ice cold with crushed ice in it. And we know that as you swallow crushed ice, that stimulates the parasympathetic and hence causes reduction in heart rate and abortion of attack of supraventricular tachycardia. The third physical maneuver is by asking the individual who has got this problem to try to vomit, and you can gag the inner side of the throat by putting a finger inside, and as he tries to vomit, that again induces or stimulates the parasympathetic system and the attack is aborted. So there are three ways of aborting an attack of supraventricular tachycardia. One, by carotid massage. Two, by ice cold water, usually crushed ice. And thirdly, by inducing vomit. And in large number of cases, you can abort an attack of supraventricular tachycardia. If this does not occur, if it does not help, then you resort to medical treatment. And in that, the commonest drug which is given is intravenous verapamil. Verapamil acts on it acts on the conducting system of the heart and reduces or suppresses the conductive system, and hence produces a reduction in heart rate instantaneously. But one has to be very cautious, because intravenous verapamil is only given while the patient is on monitor, and it can cause suddenly very severe drop in heart rate and blood pressure and can be fatal at times. So to give it very carefully in intermittent bolus doses, but never give it in speedily or in large quantities. The other drugs are beta blockers, but in certain situations you cannot give beta blockers because of heart failure or because of obstructive airway disease. So safely IV verapamil, intravenous adenosine, and beta blockers. These are the three drugs of choice. If you do not achieve success even with drugs, and these are the commonest drugs which are used, then you resort to DC cardioversion. Again, it is important that you should always cardiovert an individual while the patient is on the monitor. You should have an intravenous line. You sedate the patient and then start off with lower wattage, with lower jounce at a higher level. And we have seen this in our institute, and having treated hundreds and hundreds of patients with supraventricular tachycardia, that you can achieve success in over 99% or 100% of cases. If these are recurrent, then this is the field of electrophysiologist who can then ablate the accessory pathway which leads on to supraventricular tachycardia. You have ventricular tachycardia, which is a serious condition. Diagnosed on ECG, the patient may collapse, and most of these patients are treated with intravenous drugs like IV amiodarone, which again is an extremely useful drug. And if I have to tell you that which is the commonest dysrhythmic drug which you should learn and study the literature and use it more frequently, If you do not remember any other drug, remember amiodarone. This is one of the commonest, the most famous, and the most effective drug which can be used in patients with dysrhythmias, particularly where you have tachycardia is the main component, not in bradycardia. So, atrial fibrillation, supraventricular tachycardia, ventricular fibrillation, nodal tachycardia, or multiple ventricular ectopics. This drug is highly effective, and to date it is found to be extremely useful. We use it very frequently in our patients, either in the intravenous form or in the oral form. But please remember that long-term use of amiodarone is has got serious side effects like corneal opacities. The person may start complaining of disturbance of vision. He may have pulmonary fibrosis, so he may get short of breath. He may have thyroid dysfunction, either hypothyroidism or hyperthyroidism, or he may have liver enzyme abnormalities. So once you stop this drug, all these side effects usually disappear in weeks or in months. But an extremely useful drug which we must all remember and must read the side effects of amiodarone. Coming to ventricular fibrillation is a cardiac emergency. You get the patient in and you shock this patient. And DC cardioversion is the treatment of choice for these patients. You could also give for ventricular tachycardia or ventricular fibrillation intravenous xylocaine. That again is an antiarrhythmic drug which is very useful and can be used in such situations. Coming to heart blocks. For first degree heart block, you do not require any treatment. A large number of patients they do not need any treatment. First degree heart block occurs commonly in rheumatic fever, rheumatic carditis. So you treat rheumatic fever, nothing should be done about the heart, or in some forms of cardiomyopathy and ischemic heart disease. But it is for second and third degree heart block, particularly if they are symptomatic, that you give them sympathomimetic drugs, and they can help to increase the heart rate. And at the same time, quite a number of these patients who are symptomatic with history of syncope, unconsciousness, or falls may require temporary pacemaker for the time being, or in certain cases where temporary pacemaker doesn't help, they have to be put on permanent pacemaker. And that may be either single chamber or dual chamber. So those are some of the commonest dysrhythmias, and that is the commonest mode of managing these patients. And if summing up all this, if I have to tell you that what do we see in our cardiac institute as an emergency or in our outpatient department as the commonest forms of dysrhythmias, I would label them as tachycardia, bradycardia, ventricular premature contractions, atrial fibrillation or flutter. Atrial fibrillation is treated usually with digoxin. It is an extremely useful drug which helps. It can also be treated with amiodarone. It can also be treated with beta blockers at times if the patient is not in heart failure. You have supraventricular tachycardia, as we mentioned, how to manage that. Ventricular tachycardia, nodal tachycardia, ventricular fibrillation are relative emergencies, particularly ventricular fibrillation, and they are managed with either drugs, amiodarone or xylocaine, or DC cardioversion. And again, a word or two about DC cardioversion. I think each one of us must understand how to use DC cardioversion, how to cardiovert an individual. I think in one of our talks in the future, we'll demonstrate, and I'm sure most of you know about it, how to cardiovert a patient. This must be practiced. I've seen in a number of medical units, DC defibrillators have been kept there for years together without having been used. So every day when the nurse comes in your clinic or in the emergency, she must check that the battery is functioning, that the DC defibrillator and the jelly is available, and the instrument must be functional because it's life and death situation. For heart blocks, you have drugs, and at the same time, you can use temporary pacemaker. Once again, I think I must mention here that temporary pacemaker can at times be life-saving, and most of us who are working in relatively bigger clinics or small hospitals, they must know how to put in a temporary pacing lead and to pace an individual. It's not a difficult procedure, it's just you have to know the subclavian cannulation of the subclavian vein, introduce your pacing lead, it should sit at the apex of the right ventricle, you see it under the screening, you just adjust the rate, the voltage, etc. and the patient suddenly wakes up after he gets an episode of complete heart block and may pass out. That is again a life-saving procedure. So with those few words, I think I'll conclude here. If there are any questions, any queries, I would like to share with you your thoughts, your experience. Starting off with Dr. Mudassar. Dr. Mudassar, what sort of rhythm problems do you encounter in your day-to-day clinical practice? Dr. Mudassar Sahib.
Assalamualaikum.
Walaikum salam.
As you mentioned that the most commonly we also come across bradycardia and tachycardia. That are the common things that we used to see. And the other thing that I have seen commonly, usually on ECG are patients when they are missing beats, or sometimes just normal blood pressure patients that we used to do ECGs. We found that they have ventricular extrasystoles. So we are not using those drugs that you have mentioned. Mostly we confine ourselves to beta blockers. I want to ask this question that I have read this Valsalva and what is the use and how it is done properly?
Right, that's a very good question, and it is again a very useful physical maneuver to abort an attack of supraventricular tachycardia. It is while you pinch your nose, so you stop breathing through your nose, you purse your lips and then blow very hard. It's in the same way as if you're trying to open up your eardrums. Those of you, and many of you have traveled on the airplane or are while descending from a height, you find that your ears get blocked. Now, in order when your ears get blocked, the way to open up your eardrums, what we say through the eustachian tube, you close your nose, you blow through your mouth, and suddenly you find that you have opened up your ears and the sound travels now easily. This is an experience which we experience in the air travel, usually when the flight is descending down. Now that is Valsalva maneuver. So Valsalva maneuver is closing your nose, blowing through the mouth with the lips pursed without getting the air out. So what you're doing is you're forcing the air through the eustachian tube to push the eustachian tube outwards, and as it is pushed outwards, your ears open. You can listen now properly. But at the same time, this also stimulates the parasympathetic system, and that's how you abort the attack of supraventricular tachycardia. Very nice question. I'm sorry to have missed on that.
Thank you. There is another question.
Yes, please.
What is the role of calcium channel blockers in arrhythmias? Is there any or no? Are they contraindicated?
So you're so right. I think I did allude to one of the calcium channel blockers, which is verapamil. Verapamil is a calcium channel blocker which specifically acts upon the conducting system of the heart and suppresses it. by blocking the calcium channels in the conductive system, and that is how it reduces the heart rate. So you're absolutely right. Verapamil is commonly used and a very effective heart rate reducing medicine.
Thank you. And the patients that we used to see with occasional ventricular extrasystoles, do they need any treatment? Usually the hypertensive patients, when we do their ECGs, we used to see that there are occasional or sometime after a few minutes ventricular extrasystoles appear on ECG.
There's a very rough rule which is not 100% correct, but normally it is said that ventricular ectopics to a large extent are benign. Supposing if a patient has high blood pressure, so if I have to ask this question, which is the drug of choice you would give to a patient who has hypertension and at the same time has ventricular extrasystoles? I think we all agree he should be on beta blocker as one of the drugs. It would bring down the blood pressure and at the same time suppress the ventricular ectopics. So if you control the blood pressure, you also control the ventricular ectopics. But it is said that if you do not treat ventricular ectopics alone, usually if the ventricular ectopics are numerous, that is, they say they are more than 5 or 6 beats per minute, if ventricular ectopics come in runs, that is, suddenly you have 1, 2, 3 coming together, or as it is said, and if you see the ECG, if there is an R on T phenomena, in those cases you treat ventricular ectopics with, as you very rightly mentioned, with beta blockers. So in large number of cases, no treatment except the treatment of hypertension, cardiomyopathy, ischemic heart disease, thyroid cirrhosis, etc., etc. But in those cases where a person complains of frequent ventricular ectopics and they are disturbing. I know of a lady who came to me and says that she had to get up at night with frequent palpitations. We did an ECG and also monitored her for 24 hours, and we found that she had multiple ventricular ectopics. All blood tests were normal, everything was normal, so she didn't have any other heart problem. So we started her on a beta blocker and her ventricular ectopics disappeared. So beta blockers are one of the commonest drugs, but only to be given if an individual is symptomatic or he is worried because of his palpitations. Any other, let's share our experience from Burkina Faso, Dr. Bunu Sahib.
Assalamualaikum.
Walaikum salam.
Can you hear me?
Yes, please, we can hear you loud and clear.
Yes, thank you very much for your very illuminating lecture that you have made. I have done many things today. I didn't know about this carotid massage and this iris scorecard water. But fortunately or unfortunately, I should say that here we don't see many cardiac cases. In fact, our cardiac units here at the General Hospital at the national level is so, let us say, very backward that we don't have any special equipment. We have special there, but we don't have enough equipment. We don't do anything like these kind of procedures like angioplasty, angiography and all that. So our knowledge of cardiology is very poor, I'm afraid. And I'm learning a lot today from you. And thank you very much, Jazakallah. And I hope that we get more such kind of experiences. Just to give you an example, yes. I've never seen a cardiac arrest in my life. It's only once I heard one case and I didn't know what to do. And this is to tell you how rare we find cases of cardiac pathologies here.
Okay, okay. But what are the common cardiac problems which you see in Burkina Faso?
Yes, most cases that is hypertensive. In cases we have complications. Right. But we do have very rare cases of congenital cardiac defects. But usually these are sent abroad to get treatment, and because as I just said before, that we don't have any such facilities over here to treat such kind of cases. And really we are very much backward in this sense here. Yeah. We need some people like you who can come and develop our unit over here.
That's very kind of you. I think the first thing, in my humble opinion, you are very learned people. I think working in such an environment where you have to depend purely on your clinical judgment is exceedingly commendable. I think I must appreciate and hats off to the physicians, the doctors like yourself working in countries and delivering such good health care that it's your humbleness, your humility that you're saying that things are not that well off there. But I think we learn from each other. I think I always learn from you people, like the types of diseases which you have. How do you manage those conditions? Let me ask you another question. That how common is this form of cardiomyopathy which we see